Hello and welcome, everyone. Thank you for selecting the importance of overall healthcare maintenance in pediatrics presented by Dr. Sabina Ali. My name is Bronwyn Kierce, and I am the Manager of Education and Engagement with the Crohn's and Colitis Foundation. As a reminder, please feel free to enter your questions in the Q&A box down at the bottom panel of your screen. You can do this at any time during the presentation, and with any time we have remaining towards the end, we'll get through as many questions as time permits. This session is being recorded, and the recording will be available post-webinar in your swap card platform and account. So you're welcome to find that there. There will be no link emailed out afterwards. Again, you can access the webinar recording through your swap card account. And because we have a lot to get through this evening, I'm going to go ahead and introduce Dr. Sabina Ali, who's a gastroenterologist specializing in caring for children with either of the two main types of inflammatory bowel disease, ulcerative colitis and Crohn's disease. She's the medical director of inflammatory bowel disease program at UCSF, which is the University of California, San Francisco, Benioff Children's Hospital in Oakland. She has been caring for children with stomach and intestinal conditions in the East Bay since 2008 and is passionate about improving remission rates for IBD patients. I would love to present and welcome Dr. Sabina Ali to the presentation. Hey, Sabina, thank you.
Thank you. Welcome everyone this evening joining us to discuss the healthcare maintenance in pediatrics. It's a very important topic and I'm excited that, to talk about it this evening. I have no disclosures. So what is health maintenance? So basically it's to prevent development of other diseases and monitor for adverse effects with what the current treatments offer. Healthcare maintenance is a very important part of the care for both Crohn's disease and ulcerative colitis. Is healthcare maintenance both important for patients who are in remission and not in remission? Yes, the healthcare maintenance need to keep going on while you're on treatment, whether you are in remission or whether you are not in remission. There are a lot of things to cover as a part of your healthcare maintenance, starting from growth, vaccination, tuberculosis screening, bone health, not forgetting mental health, cancer screening, and other organ systems like eye, skin, even dental, important things like sleep and exercise, lab monitoring, and nutrition. Starting with growth, one of the most common problems in children and adolescents. This is something uniquely different in patients with pediatric IBD, and that's not something we struggle with in an adult patient. Pediatric IBD patients can struggle with growth failure associated with delayed puberty. Growth failure or decreased even height velocity can also precede even before the GI symptoms appear, and maybe also the only presenting sign and the only first sign of IBD. Nutritional deficiencies, physical inactivity, having an active inflammation, or exposure to steroids can all negatively impact bone growth. It's important to have your height, weight, and body mass index recorded at clinical visits and be followed to see and make sure that the linear growth and growth velocity or height weight gain can reflect early signs of disease relapse. For pediatric patients, there is a very critical growth window in the adolescent years, and that needs to be crucially monitored. Vaccinations. For most IBD patients, immunizations should not deviate from general population. Pediatric patients with IBD are susceptible to vaccine preventable diseases secondary to immunosuppressive therapy. Our goal is to prevent these infections. We have vaccinations and the vaccinations work. This is a updated vaccination schedule for 18 years or younger from 2021 CDC guidelines. This is a whole snapshot of the vaccinations we get from birth to 18 years. This is available at the CDC website, and also, of course, when you go to your pediatric or primary care office visits, this is what is followed. Vaccinations, when we talk about, are two big types: live vaccines and inactive vaccines. What is a live vaccine? A live vaccine is a vaccine that contains a living virus that can give and produce immunity, usually without causing illness. We have to be careful about live vaccines and should be avoided in anyone who's immune suppressed. Common live vaccines that we all know about and use are BCG, influenza, that's the inhaled version, not the injection version, measles, mumps, rubella, oral typhoid, varicella, yellow fever, and zoster vaccine. That is important for IBD patients to know about that if you are on any immunosuppressive medications that you have to avoid live vaccines, and something to discuss with your GI provider and also with your primary care. What are the inactivated vaccines? So inactivated vaccines are safe, and even for those who are immune suppressed. These are the inactivated vaccine that we need to continue for pediatric patients and should not deviate the CDC vaccination schedule. So that includes tetanus, hepatitis B, hepatitis A, the injectable influenza, pneumococcal, and HPV vaccine. All pediatric patients with IBD should receive the inactivated. So this is the injectable version of influenza vaccine every year. The live vaccine of influenza should be avoided in patients with any type of immune suppression. So as you can see on this window, the annual vaccination starts at 6 months of age and keeps going on annually till 18 years. Pneumococcal vaccine, CDC recommends routine administration of pneumococcal vaccine. So that's PCV13 for all children younger than 2 years of age. If you fall in the age group of 6 to 18 and have not received either the PCV13 or the 23 variant, there is guidelines of if you're immune compromised, what is the timing of these vaccines. And this is also available on the same sheet, and that is followed accordingly. Human papillomavirus is the rates of cervical changes and dysplasia or cancer are higher in immunosuppressed girls compared to their healthy controls. HPV infection is associated with reproductive organ cancers in both males and females. HPV vaccination is recommended for all preteens, including girls and boys at age 11 and 12 years. Teens and young adults through age 26 years who didn't start or finish HPV vaccination also need HPV vaccination. Of course, not to forget the SARS-CoV-2, the COVID-19 vaccination. IBD patients should get vaccinated against SARS-CoV-2, COVID-19 vaccine. What questions that always comes up, when is the best time? It's the earliest opportunity. There are 3 approved vaccines currently in US, Pfizer, Moderna, and the new approved Johnson & Johnson. The Pfizer is approved for 16 over. The Moderna and Johnson are approved for 18 years and over. Screening for latent tuberculosis. You probably have, if you have had any immunosuppressive therapy, gone through some of these tests, the skin tuberculosis test or the blood test called quantiferon. Patients treated with anti-tumor necrosis factor therapy or biologics are at increased risk of reactivations of what we call latent TB infection. So it is recommended to screen for tuberculosis before starting specifically anti-TNF agents, which are Remicade or Humira. Mental health should not be forgotten along with our physical health. Being a teenager is already hard. What it means to have a chronic illness, it's even harder. Physical symptoms associated with IBD can affect self-image, coping with procedures, frequent clinic visits, hospitalizations, infusions, all this can affect someone's mental health. And adherence to a complicated medical and at times dietary regimens. There is greater risk of low self-esteem, poor social functioning, and depression. It's important to your child's IBD team to talk about this. Something to also consider, and which is done routinely now, is depression screening as part of your evaluation. The question always comes up is, I had my first colonoscopy, when do I need my next one? So cancer screening via colonoscopy should be performed at 8 to 10 years from the time of symptoms, so your initial diagnosis. And that can also change depending on, you may need additional colonoscopies in between, depending on how you're doing, your treatment and response to treatment. Patients with ulcerative colitis who have a specific liver disease called primary sclerosing cholangitis require more frequent colonoscopies, sometimes annually to twice annually, with biopsies for colon cancer surveillance. They also are at increased risk of developing cancer of the bile ducts in the liver, and that's also needs to be monitored. Eye health is also something important and needs to be monitored for an IBD patient because inflammatory bowel disease, as we know, is a systemic disease. It not only involves your GI tract, but also can involve what we call extraintestinal areas, which can be eye, skin, bone. Eye conditions are reported almost 6% in IBD patients. So it's important to get an annual eye exam by an ophthalmologist, so you can get a slit exam, checking your intraocular pressure, and a more detailed exam that can be done in their office. Skin, annual skin evaluation is important for skin cancer screening and monitoring for other skin conditions. There are certain types of lesions or rashes that can appear in IBD patients. It's important to use skin protection. Skin protection consists of skin protective clothing, using sunscreen of SPF 15 or higher, making sure you are seeking shade, and limiting outdoor activities between 10 a.m. to 4 p.m. and avoiding indoor tanning. Sometimes the outdoor activities, of course, can be challenging because that's probably at times at school or in practices like outdoor activities. So it's important to make sure you are using good sun protection. Nutrition is a key part of IBD care. Healthy diet, and specifically in pediatric IBD patients, because as we talked about how important growth is, maintaining a well-balanced diet and adequate hydration. Patients should be vigilant in warm weather because that's when we sweat a lot and lose water and salt. If tolerated, dairy products should be consumed to provide adequate calcium, but other sources of calcium are available. If for some reason you are not able to tolerate regular dairy products, a lot of now non-dairy items like almond milk, soy milk are also contain vitamin D. It's also important to see a pediatric dietitian during your IBD care. The few vitamins and mineral deficiencies I would really like to highlight. The big one is iron deficiency. This is the most common form of anemia that we see in IBD care, an IBD patient. This anemia may represent that you may have iron deficiency because of chronic blood loss or poor absorption. Sometimes anemia of chronic disease because your body is not utilizing the iron stores because of the active inflammation. Some of the medications can cause other vitamin deficiencies, specifically use of methotrexate and sulfasalazine. And just you are likely, if you are on methotrexate or sulfasalazine, on folic acid supplements. So it's important to remember that while you are taking two of these medications, to continue taking your folate supplement. B12 is important because if you have inflammation in certain part of your GI tract, specifically what we call ileal inflammation, that's the area of the small intestine closer to your colon area, that's also where vitamin B12 absorption happens. And if there is inflammation in that area, B12 may be not absorbed well. If you have gone through a surgery of that area, it's also important to your B12 to be monitored, and you need supplementation. Certain diets can also lead to B12 deficiencies, specifically vegetarian or vegan, because vegetables don't have vitamin B12. Vitamin B12 is part of the animal meat diets. Zinc, IBD patients are likely to have increased zinc losses because of from the GI tract, so something also to consider. So when you are taking a complete vitamin, make sure that some of these vitamins are part of your complete multivitamin when you're taking them. Vitamin D is one of the most important vitamins that we monitor and talk about in for IBD patients because it helps promote bone health. The lab that is used to monitor is called vitamin D 25OH, and that's monitored throughout when you're getting lab drawns, sometimes once a year, twice a year, at times maybe more if you have developed severe vitamin D deficiency and you need higher doses for supplementation. Moving to bone health, as we talked about vitamin D, healthy boys and girls reach most of their peak bone mass at around 16 to 18 years of age. Factors that impact growth can also lead to abnormal bone metabolism. So delayed puberty, malnutrition, decreased intake of vitamin D, rich foods like milk products, malabsorption, you're not absorbing the vitamins, low body mass index or active inflammation, and at times use of corticosteroids. These can all affect the metabolism and lead to abnormal bone health. Active IBD also often can have decreased energy. So that can lead to fatigue, which can lead to increased inactivity. So you kind of can be in a vicious cycle, and that can lead to impaired bone development. How do we monitor bone health? There is imaging studies called bone density scans that can be done and can be a very valuable tool if someone has had severe disease or low body mass index or persistent vitamin D deficiency or exposure to steroids or history of previous fractures. Reproductive health is also important to talk about in our adolescent girls and boys. And as we kind of highlighted already, importance of HPV vaccination, routine pap smears in our adolescent females who are sexually active. Also, the question comes up is which oral contraceptives can I use? So that is a very important discussion when there is a plan to start oral contraceptives for several different reasons between your GI provider and your primary care provider, and if you're seeing a gynecologist. Smoking. Why are we talking about smoking in a pediatric? Because passive smoking can also have a negative impact on child health. So that is smoking in the household. Smoking increases the risk of flares, complications, need for surgery, and disease of reoccurrence in Crohn's patients. Ingredients like in e-cigarette aerosols could also be harmful to the lungs in the long-term care. The goals of our medical therapy and care is to reduce, to include induction and maintaining a steroid-free remission. The less steroid exposure, the better IBD care can be. Preventing disease and therapy complications, restoring the growth and puberty development, optimizing bone health, and improving quality of life. And as we talked about, mental wellness. Compliance with medications and follow-up is important. It is important that the choice of therapy and dosing is a shared decision plan, a strong relationship between your pediatric gastroenterologist based on trust, regular conversations, as well as encouragement to help the adolescent take ownership of their disease and that will help optimize compliance with the care. There are different medications that we use for IBD patients, anywhere from antibiotics, aminosalicylates like mesalamines or sulfasalazines, steroids, immunomodulators like 6-mercaptopurine, imuranomethotrexates, and the biologic therapies. All of these medications need continued monitoring for their side effects, which can include checking your blood counts, liver tests, kidney tests, glucose monitoring, as we also already talked about the vitamins, the B12, folate, vitamin D, monitoring your iron studies. And then we have medication-based monitoring. We can measure levels of your biologics and also monitoring the azathioprine or 6-mercaptopurine metabolites as part of routine monitoring. Not to forget dental, sleep, and exercise. IBD patients can have oral conditions, like even something like mouth ulcers. It's important to continue your dental care. IBD patients also need quality rest in order to keep their symptoms in check. Some studies have shown that disturbances in sleep can be the first sign of a flare-up. So don't ignore your sleep issues. If you are noticing sleep issues, not able to get a comfortable night's sleep, waking up tired, something to mention to your pediatric team. Exercise helps improve quality of life. We know that at times it may be difficult because of fatigue or a flare, but as soon as you can, get back to having a good exercise routine. So taking care of a pediatric IBD patient takes a village. It's a whole team approach, from the caregiver parent to your pediatric IBD team, to your primary care physician, to school or young adult patient going off to work or college. This is all needs to be in continuum with close communication between all these team members. I also wanted to highlight for our young adult population who we take care of, you may start seeing, you may get diagnosed when you are in your adolescent years, 13, 15, as you go through the pediatric care. We also need to make sure we transition you well, we get you ready for the adult world. During these years is to make sure you understand your disease, understand your medications. We may also have continue and do depression screening and continue your preventive health evaluation. So get you ready and be a successful transfer to the adult GI world. There is this information of what we talked about already. It's the health maintenance checklist. It's available at the Crohn's and Colitis Foundation webpage. It's something you may want to keep a copy of, take a picture and have it on your cell phone, something to, vaccines you need and the screening you need to undergo. This is also a more detailed list that is available also at the Crohn's and Colitis website. These are talk about the different vaccinations, the cancer prevention, as we talked about skin screening, colonoscopies, nutritional evaluation, DEXA scans, when do I need to get TB testing and other hepatitis infection testing like hepatitis B, hepatitis A, prior to if I need to start any of these biologic medications. So closing, patients with IBD have important general healthcare needs. So I know we get really bogged down with all these, care, a lot of appointments, but we shouldn't forget that we also, for an IBD patient, they also have all the general healthcare needs. It is important to have a close relationship and communication between your primary IBD team and your primary physician. Remember, growth is critical. Keep an eye on the height, weight, monitoring of your labs. Make sure your vaccines are updated. And along with your physical health, don't ignore your mental health. Thank you.
Thank you, Sabina. I really appreciate the information that you shared, the concise information as well. I really appreciate the logistics of everything that you provided. We are going to have time to do some Q&A. So again, if you do have any questions, you're welcome to enter them into the Q&A box down at the lower portion of your Zoom screen. Sabina, I'm going to go ahead and get started with Q&As. The first one that I received asks, what is the youngest age you'd recommend vaccinations?
So vaccinations are based on CDC guidelines. So it depends on which vaccination we are talking about. So as I said, we start, if, vaccinations are as early as when you are born, your first vaccination part can be at birth, with hepatitis B vaccinations are given. So we just basically follow the CDC guidelines. So.
Excellent. Thank you so much. The next one has to do with gaining weight and being underweight. So the question asks, why would a teenage girl with Crohn's not be able to lose excess weight even though she has been off of prednisone for a year? She was
Yeah,
underweight at the start, gained 35 pounds, but she does eat quite healthy.
yeah. So that's a great question. I think there is a lot of parts that can be involved here. So, what was the child underweight because they were not absorbing, they were actually malnourished, and with the disease going in remission, with their medications working, they gained weight. And that's probably where they need to be. I'm not sure, of course, I have to look at the growth chart individually, but, as we also have to keep in mind that IBD patients in remission are at times, as a general population, right? We need to make sure they are not gaining too much weight. Obesity is a big epidemic, and we need to also keep in mind of those things. So I think if it's a healthy weight gain, even if it was 35 pounds and now you are at a 50th percentile, it's fine.
Excellent. Thank you, Sabina. Another question asks for some recommendations or suggestions. For this individual, their daughter is 16 and has had Crohn's for 2 years. The things you had mentioned are difficult for her to appreciate the importance of. What can they do? What are some ways that you can share the importance of those?
Yeah, so it's an excellent question, and something a lot of parents and caregivers struggle with, is how to bring this importance of all these other healthcare needs for a teenager. I think it's also is how much is the child involved and understand their health issues and their IBD. Sometimes, they may be having trouble coping, as it's Crohn's disease diagnosed 2 years ago. It's still fairly new. They've probably gone through a lot in the first year. I think it's also important to maybe see if you can help there are support groups or someone like a buddy system. We do encourage that, and see if that can be helpful. Crohn's and Colitis Foundation does a camp every year. Sometimes that helps because it doesn't you don't feel like I'm the only one struggling with this. So I think those can be few things that may be helpful, but also it's maybe, having a one-on-one time with a pediatric gastroenterologist, kind of, if your child is 16, maybe having her kind of express herself, maybe it would be easier if she's willing to spend on more one-on-one time during a clinic visit with the provider.
Excellent. Thank you, Sabina. Yes, peer-to-peer support always seems to be a great option. Just to, like Sabina had mentioned, not feel like you're the only one experiencing these difficulties. And we do have a couple of questions left, so I am going to go ahead and ask Sabina for these. We may run a couple of minutes over, Sabina. I hope that is okay.
Yep.
But I'll go ahead and answer the questions that I have now, and then that will be it. The next question I have listed asks, what age do IBD patients move from a pediatric GI to an adult GI?
Yeah, that's an excellent question. I think it depends on when the patient is ready. Some patients are ready when they are even 17 and 18, and some of our patients are not ready when they're 21. So I think it's part of the transition readiness, and to work with your pediatric gastroenterologist. We are not in any rush to send you to an adult GI. We want you to succeed there. It's a very different world. So I think I would say that it's not a particular age, but most of the time patients will transfer by age 21. Sometimes it's also hard if the young adult in college and away from home, they may need to transfer a little sooner because they may need a GI locally where they are going for college, but their pediatric GI may still be involved when they return home. So I think it depends. I don't think there is a strict cutoff of when. It's when you are ready.
Excellent. Great answer. Thank you for that question as well. The second to last question I'll ask here is, have you noticed the early teen years being a common age for pediatric IBD to be diagnosed, and any opinions on the role of hormones in this first flare?
Yeah, so yes, so early teenage years, that is the most common age for pediatric patients to be diagnosed with IBD. 25% of IBD patients get diagnosed in the early teenage years. So there are kind of three peaks in our lifetime when we get diagnosed. So it can be the early teens, in the 12, 13 years, then it's in your middle, so it's kind of in the 40s, and then it's kind of more later in the life, like 65 or older. So the role of hormones, there is a lot of discussion is what hormones play a role. We know that pediatric IBD disease is a little more aggressive than when you get diagnosed when you're an adult, and whether hormones are playing a role for the more active disease, and that is always a thought. And that's when you're also growing and need more nutrition, more calories. So it's also important for us to bring your disease in remission, so you can achieve your genetic potential for your height and weight.
Excellent. Thank you so much, Sabina. I appreciate it. My final question for this evening will come up here. It asks, this individual's child currently takes Remicade. Is it feasible that if remission is obtained, are there other less invasive treatments that could be explored? If so, would you mind naming a few?
Yeah, so that's a difficult question, because depending on how long the child has had inflammatory bowel disease, whether it's colitis or Crohn's, where the disease is, how much medication, Remicade dose they are on, and kind of what led to the remission. I am happy to hear that your child is in remission, because that's an exciting always to hear and see. So de-escalation of therapy, it's something that is very difficult, in the sense is it's also, you have to be very careful regarding de-escalation, if that's what you are kind of wanting to know, is moving from Remicade to something else, because remember, Remicade brought the disease in remission. Disease is a chronic illness, so stopping medications or moving to a different treatment, which may or may not work, may bring the disease back, and the next time the disease may return may not be easier to treat or get into remission. The things we always talk about is, if you are on a certain Remicade dose and you are in remission, can the dose be adjusted, change? What if you are on every 4 weeks and something you can go every 6 weeks for quality of life, less infusions? People also look at adjunct therapies, like using diet therapy, to see if that also helps. You also have to think about is making sure the disease doesn't come back even on Remicade. So how do you prevent those things? So how do you keep the disease in check and quiet?
Excellent. Thank you, Sabina, for that explanation and providing all those recommendations and insight into that idea. I am going to conclude this webinar. I really appreciate, Sabina, you joining us this evening, providing such educational insight and valuable information for everyone on this call. So thank you so much for joining us. We would also like to, of course, thank you all for joining us this evening too, for Dr. Siegel's presentation and joining us here in this breakout room. Really appreciated your questions and bringing those forward. And before we say goodnight, we would love to invite you to check the local chapters page for any upcoming events, maybe Camp Oasis, peer-to-peer support, as Sabina had mentioned earlier. There is a lot of options, or are a lot of options available to you all through a local chapter as well. I did also submit the post-webinar survey into the chat box, so you're welcome to please complete that and fill it out. We always appreciate your feedback so we can learn from this and grow from this for our future presentations. And of course, we hope you guys are all doing well at this point, staying safe and healthy, and we hope to see you at next month's webinar on April 15th, where we'll be discussing the latest in genetics and microbiome in IBD. So we're really excited for this series. Again, thank you so much, Sabina, Dr. Ali,
Thank
for
you.
joining us. And everyone have a wonderful evening. Bye-bye.
Bye.